And I'm going to welcome everyone to, this is actually the 11th, which is hard to believe. This is the 11th session in our COVID-19 seminar series by Eastman Cares. The result of a lot of work on the part of the Education Committee. 3 of the members are here, but we also have Sally Wood and Elise Kendall, who work with us over the course of every year to try to figure out what kind of educational things we could offer to our community. So this has been this year's, and it is, this series at least is drawing to a close. I will give a few hints about how we're going to do this. First, I always have to do a plug for the Eastman Cares resource guide. This has been revised this current year and is available at South Cove, so feel free to pick this up. It's also available online at the Eastman website. And the other thing I'll give a shout out for is our eCares Connection, and that is an opportunity for anyone in Eastman who knows of someone, or if there's anyone who feels that there's a need for someone who might really like a connection. We have volunteers who are willing to call people weekly, daily, monthly, whatever the need might be. So if you know of anyone or feel like there is a need for that, we will welcome a phone call, or you can, the easiest way to do this is to email us at eastmancares@eastmannh.org, and someone will get back to you. So we encourage everybody to get the word out about that. As I said, this particular kind of webinar does not allow for video or audio for the participants. That being said, though, there is definitely an opportunity for questions and answers, and we definitely welcome them. And depending on your device, what we'd like you to do is go into the Q&A rather than the chat. Paul's going to monitor questions for Ken, and it's a lot easier if you only monitor them in one place as opposed to multiple places. So if you don't mind using the Q&A and just typing your question in, we would appreciate that. Dr. Dolkart is going to stop at the 20-minute mark and the 30-minute mark, and then of course at the end, so that if you have questions, you can just type them in anytime, and then we will address them. So we would encourage you to do that. This is also being recorded, and it will be available. All of the last, about 10 so far, are available. Lori posts them in highlights, but they're also available on our Eastman website, so that if you know someone who wanted to attend but wasn't able to, any of them actually, you can go and see them. They are they're Eastman YouTube videos, but they are definitely available. Before I introduce our next speaker, I also wanted to say that if anyone has any suggestions for future topics, we're obviously going to move off COVID. Hopefully everyone's going to be moving off COVID. But if you have any suggestions for future topics or presentations or evaluation comments about the whole series, we'd be very happy as a committee to hear from you. And it's the same thing, just email us at eastmancares@eastmannh.org. So before I introduce Ken, I want to just say a word about our final talk. Our final talk is May 14th, and that would be, what will the post-COVID world look like? That'll be Dr. Paul Epkind, who is, you can see on the screen here, and we will look forward to that presentation. That link has already gone out in highlights, and I'll be sending it out as well via the listserv. And I think that's all of my required announcements. I want to introduce Dr. Ken Dolkart. I also want to say, though, before we begin, I really want to give a shout out to Nancy Gagliano, to Ken Dolkart, and to Paul, who are part of our public health team, who have gotten us through this. They have met every single week at 8 o'clock in the morning for, God, it's over a year now, trying to help us as a community remain protected. So I definitely want to give a shout out to them, and especially to thank them for giving us their time, in addition to what they do every week, and then some, to giving us their time by doing these last 3 talks for us. So we really want to give a shout out to them. And now to Ken, Dr. Ken Dolkart. This is kind of funny. I've done at least, I don't know how many versions of the intro have been sent out. One of them said he has been practicing for 35 years. So one of them said 37 years, but in fact, it's 38 years, right, Ken? I hope I have that right. He is a semi-retired as assistant professor of medicine at the Geisel School of Medicine, where he continues to teach students in the art and science of medicine. He received his degrees from the University of Pennsylvania. And as I said, he's practiced for 37. Anyways, he's practiced for a long time in internal medicine and geriatrics in New Hampshire and in Vermont. And it is a pleasure for us to welcome Ken. So I will turn this over now to Ken.
Thanks so much. So you can hear me okay? And thanks to Sue and Paul for organizing and putting together a great series this past year, which has not been a great year, but a great series anyhow. So basically, as summer is now approaching, perhaps here in New Hampshire, we're moving to a vantage point from which we could view this epidemic more from a distance. As you might know, the US deaths from the American experience surpass almost any other experience except for the 675,000 people 675,000 people who died in the 1918 influenza pandemic. And this has been the greatest single year spike in death rate since federal statistics have ever been recorded. So despite genuine knowledge breakthroughs, the US has seen a disproportional course of illness and death. And even now, of course, worldwide, the peak devastation has not yet crested. We're seeing a staggering 300,000 cases of COVID daily in India. However, this past year, there really has been remarkable scientific progress made in understanding some of the unique aspects of this virus, with some applications in treatment and deployment of truly inspiring new mRNA vaccines that will likely change the course of this as well as future infectious diseases. So we'll end, I think, probably on an optimistic note. With just a review of the goals of the presentation, we're going to take a look at the regional outbreaks that erupted across the country, do a little bit of comparison of international experiences. We'll look at mortality as associated with age, obesity, occupation, and disparities in race, ethnicity, and social determinants of health. If we have time, we'll look at some novel biological aspects of the SARS coronavirus 2 and learn what makes a particular individual susceptible. So, there we go. So on January 20th, this might look familiar. January 20th, a year ago, 2020, the first US case of COVID was reported in the community north of Seattle, Washington. This was a 35-year-old man in this case who had returned from Wuhan, China after visiting family, and he became ill and was hospitalized. That case was rapidly followed by a community-level outbreak with rapid spread and high mortality among older adults at the Life Care Center in Kirkland, Washington, where this picture is from. At that nursing home, ultimately 2/3 of the skilled nursing residents died, and 47 of its workers became ill. 35 people died in all. And this event was a harbinger of the devastation that would basically befall nursing homes in New York, New Jersey, and across the country. In Washington State, where this occurred, there was initially very little testing and very little public health support at the outset. So other outbreaks occurred in nursing homes near Kirkland, where asymptomatic health workers often brought COVID into the facilities. However, the region rapidly geared up to implement stringent isolation techniques and protective measures, such that local living facilities were able to bring this under control fairly rapidly. That outbreak is sort of here, and looking at this curve, you're surely thinking about New York. So the outbreak in Seattle was the wild type virus from Wuhan, and was able to be rapidly mitigated, but the outbreak in New York that shortly followed was of the European variant that you may have remember was circulating in Italy. Before a lockdown could be instituted in New York City, the virus really had been spreading exponentially. It was untracked and unchecked really since January. It was during this time, unfortunately, that the CDC had failed to deliver some of our homegrown tests for testing for the presence of coronavirus. So health authorities really couldn't track things during that period. Only come February 29th did the FDA lift restrictions that prevented state and commercial labs from developing their own diagnostic tests. And a lot more tests thereafter became available. As you might remember from Nancy's talk last week, they are becoming plentiful. Also around this time, the CDC was not yet recommending mask wearing, either based on the science and based on the absence of personal protective equipment for healthcare workers. So during this time, of course, the city became decimated. Between March and May, at least 32,000 people died, which is 1 in 500 New Yorkers, died of COVID-19. Emergency medical technicians, EMS folks, would often arrive in an apartment where they're called and need to pronounce the victim dead of what would often be written down as a presumed cardiac arrest, because again, testing was not available. So those cases were not reported as COVID related, and there's probably underestimation of mortality related to the initial outbreak. Not long thereafter, emergency rooms and of course intensive care units were overwhelmed. And as we've later learned, some of the undercounting also was happening in nursing homes. Some nursing home patients were sent to the hospitals and automatically returned to the nursing home after their diagnosis of COVID. They just were overwhelmed. They did not have the capacity. By the way, this is not unique to New York. There's the Empire State Building. These are the refrigerated morgues. But occurred also wherever there was densely packed population centers. So New York City, Chicago, Atlanta, New Orleans were all hit hard early on. New York City was criticized for not instituting, however, early lockdowns or precautions about public transportation or use of its subways. By comparison, almost 7 million people in San Francisco were confined to their homes earlier on March 17th. And by March 20th, California put all of its 40 million residents under near lockdown. So early on, actually, California did quite well with very few deaths. Unfortunately, the New York City stay-at-home order didn't go in until March 22nd. And its school system, which had 1.1 million students, was not closed until March 15th. Excuse me, well after other cities had shut down. This is the daily deaths reported. That's really a exponential curve of an epidemic breaking out. So this initial wave clearly was among the major cities, excuse me, which were also transportation hubs for air travel and the like. Around this time, however, there was an absence of White House sponsorship of the CDC recommendation, which did get made in the beginning of April for the wearing of protective masks. There was also a push by the executive branch to open up for economic reasons. So many governors in the southern states allowed public health measures to lapse come the late spring. There was actually, if you may remember, also a lot of coordinated interstate decision-making made in the Northeast, among the states of the Northeast, many Midwest states, and Pacific Coast states. However, the South was lulled in some complacency that the New York experience was an aberration, and perhaps they were hopeful that the warm weather would result in dissipation of the pandemic. So unfortunately, Florida, Georgia, Texas, Arizona, and many other southern states actually never issued statewide mask mandates or allowed them to lapse. This is the exponential curve that was experienced in Florida in early early summer of 2020. Memorial Day was here on this same time frame. So as the warm weather came, lots of folks started to enter back into air-conditioned restaurants and shops. There was limited capacity, but still no one was wearing masks. Beaches were opened, and the stay-at-home orders in Florida were limited actually in the beginning of May. And so Memorial Day came, and the subsequent new wave followed. So what you're going to see here is sort of an undulating wave. This is all the states of the Union in various colors. This is New England and Northeast. This is South and Southwest, Rocky Mountains and Far West, and Great Lakes. And following the New York experience, the second wave was felt primarily Texas, Florida, Georgia, Arizona, less so, but also developing in California during the second summer wave. And as you know, the hospitalizations lag behind the onset of cases by 1 to 2 weeks, and deaths would lag behind that by 3 to 6 weeks. But as you might see across most of the nation, by October, with the cooler weather and the impending holidays and reopenings happening everywhere, we entered into a really deadly third wave. Northeast actually was the exception. We did fairly well. It was kept under control in this neck of the woods. And of course, January 21st was the deadliest month in the US by far, and more than 3,100 people died every day during January. On 6 of those days, more than 4,000 people per day died of COVID-19. And by February 22nd, we exceeded 500,000 people who had passed on. What do we make of this? You know, in the absence of really a federal plan, containment strategies vary very widely by state and region. As we talked about, after initially discouraging it, CDC recommended wearing face masks in public settings. But of interest, there's some behind the scenes knowledge that's come out. The CDC wanted to emphasize face masks would be helpful for Americans throughout the country in every region, since it was becoming increasingly difficult to designate a particular spot as a hotspot due to the community spread. The executive branch insisted that the CDC guidance emphasize the use of face masks only in those areas where there was known widespread community transmission. Again, unfortunately, this was at a time when testing to determine community transmission was haphazard and very incomplete. This is a cumulative map, not from a couple weeks ago from the CDC. And of course, the largest states with the largest outbreaks as a consequence would have the highest cumulative numbers of mortality. This is a little different. This is a number looking at COVID cases per 100,000 people. It's a lot different. Rhode Island suffered, but also some of the smaller rural states had much higher percentages given the nature of their communities. Again, we've done pretty well in the tri-state northeast portion with less than 7,000 deaths per 100,000 people. Not so well elsewhere. And as you might remember, there was a Sturgis motorcycle rally in South Dakota, which actually spread to a lot of regional states as well. Minimization of risk was common in a lot of rural areas because in part because no one knew anyone else who was ill, but in part also because it reflected political issues rather than public health priorities. Clearly, by the time the winter had come around, most Americans had gotten the picture once again. A brief discussion of international comparisons. A lot of the nations of the world, when outbreaks developed in those countries, the initial pandemic outbreak looks the same. Many of these curves are curves that you see with exponential growth early on. These stars represent the first lockdowns that are being implemented. And again, although early experience is fairly the same, the seriousness of interventions varies dramatically. There's 2 countries I will talk about a little bit later that are outstanding. One is not on here, and that's Taiwan, and the other one is New Zealand. The case counts and death tolls in later stages after the pandemic mitigation has been implemented, however, look a lot different. Here we see confirmed cases. This is not a logarithmic scale. This is just a numerical scale. Here's the US. Here's the New York experience. Here's our second wave in July. Here's our third wave. And you can compare that to the work that a lot of other countries were doing in maintaining attention to the epidemic. This is Brazil, whose numbers are now climbing and have now exceeded 400,000 deaths per their population. This is India. Did initially some yeoman's work, but now, unfortunately, are experiencing catastrophic outbreaks. So, and this, of course, is a familiar national map. I want to bring up the case of Taiwan because it's really illustrative. It's really quite interesting. Taiwan is a nation of 23 million people on a small island with very high population density. This is Taipei, its capital. And Taiwan experienced the SARS outbreak in 2003, which is very similar. The severe adult respiratory syndrome was also a coronavirus, very similar experience. It spurred Taiwan to create and rapidly implement plans for managing a future pandemic. And they knew how vulnerable they were next to mainland China. So drawing on that experience, Taiwan created a culture in which contact tracing and testing technologies, early screening of international travelers, and border management of travelers for infectious disease was available to be put in rapidly. The other thing is in Asia in general, certainly in Taiwan particularly, a lot of people are already wearing face masks. Now, they're not wearing it for necessarily pandemics. Turns out a lot of people wear face masks because they feel it's going to protect them against pollution, but it wasn't the worst thing in the world that they were doing so. And as a result of all these interventions, Taiwan has done a remarkable job. This is number of confirmed cases measured in the hundreds. That's 400. And this is the daily confirmed cases in Taiwan. Right next to China, they had strict quarantine and isolation, contact tracing, and the like. And if you look at their cumulative cases, they have pretty much plateaued throughout this pandemic, which is remarkable. Hope it stays that way. Hopefully it will. This is actually New Zealand, which has also done a fairly remarkable job using those same techniques right at the border and thereafter. They've been able to maintain a fairly impressive total of 1,200 patients. These are cases, not deaths. So I think we could bring away some international lessons, which is air hubs get hit first, such as Milan, as remember from Italy, London. Rapid closure of international borders in concert with early testing and ongoing monitoring is essential. Lockdowns work, and theorized trade-offs, which have been proposed between protecting health and a trade-off between that and the economy is illusory. Most countries did just fine who instituted such more rigorous lockdowns. Seriousness of response, cooperation, the CDC did not have shared cooperation. They did not want to use the WHO testing early on, and of course, poor leadership. Minimizing the disease, suppressing data, discouraging testing, and mask wearing resulted in high mortality. And we could look around the world to see documentation of that. Premature lapses also fosters failure, with India being a recent example. So even if you get science right, you need to get the messaging right as well. So we're going to move on now, but maybe this was just I'm running a little bit behind, but if there's a lot of questions, we can go on. I'm going to have a lot more sort of epidemiological charts. We may want to save those questions for maybe 5 or 10 minutes. Sue, does that work? Okay. Okay, great.
Do no questions right now.
All right, terrific. So, okay. So this is a discussion of mortality and age. So now we're moving towards personal risk factors. And this is the number of cases documented in the US between March 1st and April 21st. And what you'll see, no surprise, is seniors took a major hit, mostly in that nursing home setting, then in the third wave. And now, fortunately, along with the rest of the population, we're seeing dramatic declines. But this is age 18 to 24, age 25 to 34, et cetera, younger ages. A lot of those folks were not being detected because they did not present ill, and the testing was not available. As the testing became available nationwide, we see actually what the genuine distribution was around the country. Unfortunately, we also see, this is mortality. So that's actually not, whoops, forget that, this is actually mortality. And again, that early bump among seniors, but here we're starting to see mortality by age groups increasing. That's not right. This is, hang on, mortality increasing later on. So these are the seniors throughout, but now we see the younger ages starting to become a larger percentage of those who have passed on. Again, vaccines playing a large role going forward, but it's also community spread and better knowledge about how to treat the disease that was playing a role. This is a donut chart for the state of New Hampshire. Just to reiterate the number of cases based on age, minimal among toddlers, 4% at most, 10% up to age 19, 20% in 30s, 15 in one's 30s to 40s, at 11% age 60 to 69, and only 5% and 6% in more older populations. Where were these infections occurring? Only 12% were in the nursing home setting. However, almost a little more than 9% were among healthcare workers. This is community spread. All the other folks in New Hampshire were getting infections in their communities. And if you look at the donut chart of deaths, again, the vast majority were in long-term care settings, small percentage in healthcare workers, but still 20% of folks outside of that setting. There's a reason, so I'm going to stop there. Well, actually, Paul, I could move on if the questions are few. I'll keep talking.
No, there's just one. There's
yes.
just one. Oh, there is
Sure.
a question.
Sure.
Vivian's asking, what would work in terms of messaging for promoting vaccines currently?
You know, it's interesting. I think what's important is to reiterate the importance in one's community and to remind people of how far we've come. The problem is when folks don't know people who have been ill, they may be less motivated. You're very motivated when someone you love has died. I saw a nice PDA or public service announcement, PSA, by a woman whose dad had died and none of the family had wanted to get vaccines. Sometimes those can be very compelling messages to help bring it home. Stories often have the most important message to provide. So I don't know, I'm not in that field, but that's just a suggestion.
And the other, there's a question whether, are you using a pointer?
Am I what?
Are you using a pointer?
I thought I was. I was wondering if it was driving you nuts. I have a little...
No, it's not visible.
Oh, I'm so sorry. Okay, so the answer is yes and no. I'm using one, but you're not saying it. So I don't know if I have a pointer on this, but I'll bear that in mind. I'll just move. Okay.
Okay, we're all set. Thank you.
Okay, all right. So the Kaiser Family Foundation recently put out a really important study that noted that the U.S. doesn't just have total volume of folks who have died in the U.S., but more young people compared to peer modern nations. That is, we exceeded increase in mortality among all age groups. There's something called overall excess mortality. That is, if you look on a yearly basis how many people have died, this more people died this year as a consequence of the pandemic. And that also translates to numbers of people who had premature deaths and such the highest number of years lost among peers nations of life lived. So if you look here, this is from Kaiser Family Foundation, in all the various age groups, except for the very young, we have greater numbers, even though they're small, among all age groups, not just folks greater than age 75. Belgium, for instance, had more people who were elderly or over age 75 die than we did. But look at the difference among people aged 65 to 74. Not quite twice. Belgium, who had similar numbers, definitely more than twice when it comes to the UK, Switzerland, and elsewhere. So it really cuts across the board. Let's dig down a little bit to understand this. This has to do with disparities. So if we look at the counties of New York City, of metropolitan New York City, you'll see here's the Bronx, Queens, Brooklyn, Staten Island. And this was from early on. This was during, probably April or May from the New York Times. You'll see very high concentrations of death in the areas where there is the least income. And gee, I wish I had a pointer right in the middle of your screen. I think I'm pointing, but I'm not. Well, anyhow, if you look where the middle of your screen, you'll see Queens, up north, Bronx. There was a correlation with income, household occupancy, number of people living in the home, ability to socially distance in the nature of your work or home, and the percentage of folks with insurance. And here's another way to graph that. These are almost straight lines. If you look at folks in the Upper West Side down in the lower right-hand corner of the left side chart versus people in the Bronx on the left upper side, there's a straight line between income and the number of people who suffered COVID. This is by cases. Not just income. If you look at people living together, people per household, on the right-hand screen, you'll see, of course, Upper West Side has much fewer cases than that on the other side. The consequence of that, unfortunately, is not just cases, but hospitalizations and deaths. So the number of African Americans, Hispanics far exceeded their population in the city. This is also still in New York City. And their deaths far exceeded, doubled that of folks in higher economic regions of white race. This is not just true in New York, it's true in cities across the country. This is Atlanta, the same numbers. And these are early numbers looking at the nation as a whole. This is age-adjusted hospitalization rates due to COVID by race and ethnicity. And on the left, the dark blue bar is non-Hispanic American Indians or Alaskan Natives. The light blue bar are Blacks in the US. The lighter blue bar is Hispanics, and then you have Pacific Islanders or non-Hispanic Asians and whites in the US. So there is really quite a degree of variation. If you are Alaskan Native or American Indian, you suffered more than twice the risk of dying. Same if you're Hispanic, and twice the risk if you are Black. And again, this comes across all the various age ranges. So if you were wondering why we have higher loss of years of life in the US, this is the best explanation, because that disparity accounts for the difference by races in the US. Again, let's spend a minute perhaps talking about social determinants of health. This is a widely used description of what gets people sick outside of their interactions in the medical system. Some of the reasons people get sick is they don't have any options to be in the medical system. If they're low wages and they can't afford medical care, if they are undocumented immigrants and they are fearing applying for insurance because they don't want to be deported or have family separations. So there's the medical issues, also language barriers if you can't understand the brochures you're being handed, and underlying literacy. But then we get, of course, to crowded housing, as we talked about, transportation, absence. If you lose your job, and this applies to everyone, numerous Americans lost their jobs, numerous Americans lost their health insurance. If you're low income, you may not be able to afford the health insurance, of course. So there are various effects of this. And speaking of health insurance, which is an area of my interest, the lack of health insurance is greatest among Latinos and second highest among Blacks, as you see in the chart. Almost 18% of Latinx do not have insurance. Almost 10% of African Americans do not have insurance. What that means is you get in for care late. So I'll briefly discuss this, which I think is widely felt by many primary care doctors like myself. Essentially, the US health system behaved as we would have predicted. It's not a surprise. We have a poor track record in health outcomes compared to modern peers currently when it comes to life expectancy, infant mortality, and maternal mortality. And the vulnerable, least wealthy US populations, which are currently underserved and currently are suffering with these disparities in outcomes, also suffered the most under the pandemic. And of interest, affects us all, no matter what your income is, that if you were in a nursing home, your risk was both your biological risk, but also staff who are coming in from underserved areas or do not have insurance, unwittingly, without knowing that they're infected, are bringing in the cases of COVID. And we did experience that early on. So this is just data about American infant mortality. We're at the bottom in that blue bar compared to all the other industrialized nations above us. This is amenable mortality that we already experienced. This is prior to COVID, by the way. Amenable mortality means if you have diabetes, your diabetes is well cared enough so you don't suffer an amputation, you don't suffer a stroke, you don't suffer a heart attack. If your diabetes is not being treated adequately, you will suffer those consequences. So this is what's called a rate of death amenable to proper health care, of which we lead the world. And the average is right next to the right bar, which is the US, which is the average for the other comparable countries. Okay, so we have health systems, we have disparity, we also have occupation. And here, as we discussed a little earlier, healthcare workers did suffer a major hit early on. The effect on my peers, on the frontline workers, I'm not a frontline worker, but many of colleagues were. And the absence of PPEs, personal protective equipment, masks early on was devastating, such that 20% of the cases from between February and April were among healthcare workers. And many of these frontline emergency workers in the emergency room, nurses, clinicians, they were burdened by overwhelming numbers of folks coming in, critically ill patients. Medical staff needed to attend to really innumerable isolated patients who are in their ICUs, dying alone, at the same time that they had to worry about bringing home the virus to their own families. So this was really a hard hit to the frontline medical docs and nurses in our communities. In another community of workers, it was also a major hit. So this is the meat and poultry processing plants with inattention to crowded conditions and poor ventilation. Many of these factories were in the Midwest. And one thing that I remember is it was very atypical for the CDC's response. I've seen the CDC, the Centers for Disease Control, do some really remarkable work in our nation. I watched them when they were involved with a host of things, whether it be Legionnaire's disease, whether it be salmonella outbreaks. They would go in, discover the origin of this outbreak, actually discover new diseases like Legionnaire's disease or the like, make hard and fast and strict recommendations. The CDC took a lot of criticism because they were making essentially meek suggestions without means of enforcement. So, and that was true for the meat and poultry industries. So that also contributed to some of our recent history. I'm going to now change gears entirely, and this is going to be talking a little bit more about the biological aspects of COVID when it comes to individual susceptibility. So I hope I've still got your attention. I'm not sure who's out there yet, because I'm only looking at my side of the screen. But I want to talk a little bit about the immune system. So we know currently that there's an incubation time probably of about 5 days between exposure to coming down with the illness. The vast majority of people, at least 40%, that's probably an underestimation, will have either asymptomatic or mild disease. And these are probably folks who come to medical attention. Moderate disease will be in 40%. You could still receive care at home. Severe disease, which starts to develop around day 8 to 12. This is where you're starting to require, you will be requiring oxygen. That's about 15% of people. Critical disease, where you need high flow oxygen or being put onto a mechanical ventilator, is in 4 to 5% of people. So we know that older folks have sort of senescent immune systems. By that I mean, an example is the need to receive the Shingrix vaccine, the shingles vaccine. What happens with shingles is it's a local outbreak of the chickenpox virus that we've had under wraps in our body since childhood. So the Shingrix boosts those memory cells called T cells that boost their response to keep things under wraps. So that senescence of the immune system is a major issue that plays a role with the elderly. However, one of the interesting things we've learned from this past year is the coronavirus will often kill due to a heightened inflammatory response, sometimes referred to as cytokine storm, which results in a lot of the lung damage. We'll talk about that. In older folks, of course, having comorbidities, multiple other medical conditions, plays a major role in the toll on the elderly. So obesity is one of those medical conditions, which is quite interesting. Doesn't always apply in other illnesses. Same thing with diabetes, hypertension. Certainly immunocompromised states, certainly decreased functional capacity because resulting in nursing home placement, certainly lung disease. But there's some other unusual issues. So this is mortality based on having obesity, hypertension, and diabetes. Maybe we'll spend a minute talking about obesity and diabetes as risk factors. I'm putting them together on the same slide because many of the issues are shared by those two disorders. It is known if you have obesity or if you have diabetes, you already have an increased daily state of inflammation in the system. There's a lot of things that play a role with that, but that's well known. It's one of the theories that goes into other disorders, including atherosclerosis, that people have. The other interesting thing about this particular SARS coronavirus is it binds to a receptor on the cell that's called an angiotensin-converting enzyme 2 receptor. Sorry about the long names. That receptor and the angiotensin system, the angiotensin-renin system, is also tied up with hypertension, tied up with cardiovascular issues. Blood vessels are dilated or constricted. Blood clotting occurs or doesn't occur to some extent due to increased levels of angiotensin 2, one of those proteins in that long cascade of proteins. So that also plays a role. And by the way, I do want to say now before I forget, ACE inhibitors, which many of us take for high blood pressure, that includes lisinopril, enalapril, losartan, Diovan, etc. A whole bunch of ACE inhibitors and angiotensin receptor blockers have been undisputably proven safe in patients with in either before you get COVID or if you get COVID. Doesn't increase your risk of getting it, doesn't increase your risk of dying of it or getting sick from it. In fact, some studies suggest that it might be possibly protective. So please don't misconstrue this ACE receptor stuff if you're taking an ACE inhibitor. It's safe, you're on the right treatment. But ACE2 receptors are also higher in quantity in fat tissue. So adipose tissue, fat tissue, can serve as a delayed reservoir for the virus to be shed for longer periods of time and take a longer period of time to clear. Clearly, when it comes to obesity, it can impair how one responds to being ventilated. It impairs lung function and a host of other issues. If I'm doing okay for time, and Paul, shout out if I'm not, and Sue. This is some slides on the immune response in a particular individual to COVID, to many coronaviruses, many viruses in general. And this is a healthy response. So there's something called the innate arm of the immune system, which is really vital for control of a virus when it enters our cells, particularly when we don't have preformed antibodies. We've never seen the virus before. We don't have antibodies to latch on and bring that under control more rapidly. So that's the innate arm. This middle picture the picture to your left, you see what you might misconstrue as a tooth, but that cell, that pale looking cell in the middle, that's a cell that's infected by a virus. Cells have the capacity to put out that green hexagon above it, or the dodecagon. That green thing is called interferon. So infected cells put out what's called a cytokine or interferon. Interferon, as you'll see below that slide and to the right side of the slide, recruits, it attracts a whole bunch of other types of cells, the majority of which are lymphocytes and macrophages. These are cells dedicated to taking care of an infection, but not bacterial infections. They take care of viral infections and other infections. Whole bunch of, and if you look on the right side, that CD8 lymphocyte below the middle cell is basically attacking the cell that has the virus in it and killing it rapidly so it doesn't release further viruses. And the right systems are engaged to bring the infection under control. As we're learning, severe COVID-19 is often related to amplified and uncontrolled release of those cytokines. Excuse me. Sorry. And that phenomenon has been called cytokine storm. So it's an unbalanced release of that interferon that we discussed, as well as, importantly, as you see below the slide, an IL-6, that's interleukin-6. And this creates a cascade of other proteins that get engaged, as well as if you look to the right where it says neutrophil, that particular white corpuscle kills bacteria. It's dedicated to killing other cells, but unfortunately, it also gets engaged to killing our healthy cells. So this cytokine storm really causes damage to the delicate lining of the sacs that oxygen gets absorbed across the lung, called alveoli. There are little arteries, tiny capillaries that oxygen enters into to get oxygen into your bloodstream. They're damaged by those neutrophils, those white cells, as well as the cytokines. And hyaline membranes get formed. There's a lot of issues, as well as clotting, which you may well be aware of. So there's increased clotting both occurring in tiny arteries as well as in large blood vessels, causing large blood clots. Here are just some illustrative pictures of, actually these are moderate, these are not severe cases of pneumonia. That pneumonia is essentially all the mechanisms we've been talking about related to cytokine storm. Of interest, we've now learned that influenza, which would often cause, in some patients, a picture like this, is probably also due to cytokine storm. So we've now learned about applying this to our knowledge of treating other viral pneumonias and serious infections. I thought I eliminated those. I guess I didn't. So here are, we've made some advances in treatment. And this is an update. We had a treatment review earlier, but this is a little bit of an update in May 2021. Again, if you have asymptomatic, pre-symptomatic SARS, you really don't need any treatment. If you have a mild illness with mild symptoms, you probably do not need treatment. But as that disease pathogenesis slide shows, you're still having plenty of replication going on. On the other hand, if you're older, you have comorbidities, other medical issues that puts you at high risk for getting sick. If you've got diabetes, if you've got obesity, if you've got cardiac disease, then even if you have mild illness or certainly moderate illness, we'll start engaging antivirals to bring down that viral load while it's still replicating with medicines such as remdesivir. Or if it's a moderate illness and your oxygen levels are on the border, as they were or they're frankly low, we'll give monoclonal antibodies. These are preformed antibodies that have been developed in the lab, since your body doesn't have them yet. They're transfused into your bloodstream, they latch onto the virus, and they drop the viral load very rapidly. So for folks at high risk or developing in the more moderate stages of illness, I think in the science that suggests that we're underutilizing those monoclonal antibodies. These are things called bamlanivimab and etesevimab. Can't pronounce them, which is one of the reasons maybe we're underusing them, but they're very important. Later on in this graph, you see when someone is developing critical illness, a lot of it is due to the cytokine storm, to inflammation. And what's been developed, some of the developers have been, Rich Zimmerman over at Dartmouth Hitchcock has been studying some of the inhibitors to interleukin-6. So there's now new breakthroughs that we're using to treat the cytokine storm. An old treatment, which is high-dose steroids, is now part of routine care for patients with severe COVID. Even dropping oxygen levels will start high-dose steroids, dexamethasone typically. Or again, some of these newer interleukin inhibitors and other cytokine inhibitors. A couple of other advances that we've learned over the past year, we're very aggressive in treating blood clots because we realize now how common some of those mechanisms are setting up clotting in the bloodstream. So with anticoagulants. And lastly, just in the mechanism of how we ventilate patients, we're doing proning, which you may have read about. Patients are lying on their stomachs when they're ventilated rather than on their backs. So we're making progress. I'm just gonna, and along those lines, the progress we've made has resulted in decreasing in-hospital mortality. On the left side of this graph is March, on the right side of the graph is November. And we're actually even better now in April. As you see, early on it was a learning curve. The top line is those over age 75 in gray. The blue line is those age 50 to 64. In April and May, fairly high mortality rate, above 30%, almost 38% in April. That's dropped now substantially, even in folks above age 75 to less than 20%. Also dropping in all the other age groups. We've got more ways to go, and utilizing these drugs more commonly needs to be done. But I think we've seen some real progress, not just with the vaccines and preventing the disease, but in treating it once it's developed. So just some funny stuff to, not so funny, but curious stuff such as COVID toes, which looks a lot like chilblains. This is common in young kids in their around age 10 or 12. These are not necessarily ill patients. This is often in mild cases of young people. Looks a lot like pernio or chilblains. And then, of course, something that's not so mild is also in children is a multisystem inflammatory syndrome. Again, it's fascinating how one disease sheds light on another. When I was in training at Children's Hospital in Philadelphia in 1979, we would see patients, young kids, who had Kawasaki syndrome. And this is a serious illness which would cause terrible breakdown of the skin of the lips and the mouth, neurological issues, and always cardiac issues. And what we've learned now is this is a common disorder now seen related to SARS, coronavirus 2. The same spectrum of severe illness in children, again, almost always with cardiac involvement, sometimes shock, and a variety of other disorders. And again, it could be anywhere from, if you look at the right side, COVID-19 associated multiple inflammatory syndrome due to COVID, KD means Kawasaki disease-like illness. And we're now learning that that disorder may be treated in the same way that we're treating COVID-related illness with actually agents that are interleukin inhibitors or other agents for cytokine storm. So we're able to treat that a little bit more successfully than when we first recognized it as well. So that's some of the optimistic stuff that we've been able to encounter this past year. And I'm going to stop. I'm not sure if anyone's still out there. I got to minimize my screen share and see if anybody's still awake. I hope, thank you for attending, and I hope this was helpful.
There are no questions.
I don't know what that means. That's a bad sign, I thought.
Thank you, Ken. That was very interesting, actually, and I think you did a great job of simplifying what is can be a very complicated subject. And so I really appreciate that.
Sure.
And well, we have something in the Q&A. If I keep talking long enough, people can type in.
I can see faces again. It's nice.
Yeah, Bob is saying thank you very much. Very informative. Good review.
Yeah, so I would agree. And again, I would encourage everybody to join us on May 14th for the last of these series. Something has popped up in chat here.
So there is one, Vivian has a question. Is the risk factor for children the same as adults? I'm not sure.
So the similarity between risk of developing COVID in adults is if you have immunosuppression. If you have cancer, you're getting treated with chemotherapy. If you have obesity. So remember, children's up to age 18, but unfortunately, yes, many of those same risk factors hold true. And many of the young people, if you look at who gets sick, many of those folks do have obesity as a risk factor. On the other hand, it's idiosyncratic. By that I mean it's unpredictable and probably has to do with how a young person's innate arm of the immune system works and whether they produce too many cytokines. We don't have a way to, we could say on average, over age 65, you're at increased risk. Not the same and among all 0 to 5 and 5 to 10-year-olds, that's not the case. But yes, when it comes to some of the personal medical issues such as obesity, which is, we're seeing all too much diabetes in young people as well, and immunosuppression, those are risk factors, yes.
Thank you, Ken. Anything else, Paul?
No, just another very nice comment from another Susan.
Okay. Well, thank you again, Ken. It was very much appreciated. It was a great talk. Oh,
All right, I guess we'll have this as the last question.
okay.
Why is Sullivan County considered at high risk? This is from Lawrence.
Yeah, it's interesting. So a lot of that we're a fairly rural county, and a lot of that is based on cases per 100,000. Now, in reality, if you look on the New Hampshire website for the number of cases per 100,000, you'll see we're a heck of a lot lower than Southern New Hampshire, most of the towns in Southern New Hampshire. So in terms of incidence of cases, we're doing a lot better than a lot of other places. And actually, that's really more a public health and epidemiological question that I might slide off the hot seat and share with Paul.
We should have ended this 2 minutes earlier. No, when you get into rates and you have small numbers or relatively small numbers, things can appear or the numbers don't look good. In terms of why so many cases in Sullivan County, I don't know what the immunization uptake has been, and I'm not sure with a more rural county. Chances are this is also a lower socioeconomic group, and so there may be more folks in that amorphous category of essential workers who may have had higher exposures in their day-to-day work lives.
Right.
Is there a nursing home issue?
Yeah, it's just, you remind me in terms of unique issues to the county, not just the numbers. The Sullivan County Nursing Home did take a major hit. There was a large outbreak there that's been under control for some time, but it did take a hit early on. There's a number of nursing facilities that actually others have done pretty well. There's also Claremont, as Paul was saying, that has seen a lot of local outbreaks. The other curious thing is you might look on a website, oh, Vermont has doubled, it has doubled the number of cases over the course of the past month. They have all these arrows heading up. But if you actually drill down and look at the numbers, you'll see, well, they had 23 cases last month, and now they have 46 cases. So yes, they've doubled, but the numbers are often small. So some of the statistical accounting can be a little misleading, important, but misleading. Yeah.
Okay. Thank you. Thank you all once again. And as I said, I look forward to seeing people for the final talk on May 14th. And enjoy the rest of your day. It's, the sun seems to have disappeared, but hopefully it will return. Thank you all.
Get out while you can.
Yep.
Thanks,
Bye-bye.
Ken.
Take
Thank
care.
you, Ken.
Pleasure. Thank you.